very good grasp of that for your test so you could identify, a symptom that goes with it or what does it mean. Patients are going to ask you, what do I have? What is it, right? You're gonna have to explain it to the patient. So looking through your study here, it says, what comorbidities does Jim have? So that's a fancy way of saying, what medical problems does he have that's relevant? Because you're gonna see some stuff on here that really aren't relevant to a diagnosis of COPD. Okay, so look at the medical history. What things in there are relevant to know for this person? Okay, so just kind of looking through here, and we skipped over one, but just making sure we look. Flattened diaphragm with an increased anterior-posterior is what AP means, anterior-posterior diameter. Okay, so that tells me that on an x-ray, that's what his shows. Does that happen overnight? No, you will not get hyperinflation in your alveoli after having a diagnosis of a couple days. So let's say, moving forward to your test, when we start learning about like RSV and asthma, what if you got diagnosed with asthma at 5? Are you gonna have a barrel chest? No, it doesn't make sense, right? There's not been time to accumulate that problem. Okay, it tells you COPD. This is the new thing we haven't learned yet. FEV1. Anyone know what that is? Ever heard that before? What's that? Pulmonary function test, okay? We typically as nurses care about one thing in a pulmonary function test, and that is it. So it's called your forced expiratory volume. And the one refers to in 1 second. And I'm going to demonstrate it in a second here. But your forced expiratory volume over 1 second. I'll say it again because some of you are typing. Forced expiratory volume over 1 second. So it says it was performed 6 weeks ago, so pretty recent I would say. And it was 38% of normal predicted. So you want to be at 80% or higher. 100 is great if you can get there. But 38% compared to 80, just think about that for a second, okay? Now, if you were to look at the word forced expiratory volume, that would mean that you're forcefully expiring. It's the volume of air that's coming out of your lungs over 1 second, okay? So we can all do this, but this is probably one way to like spread infection because you're gonna have some like forceful air, right? Where no one breathes like that. But if I'm over here, I'm going to take a deep breath in, take a deep breath out. So when I take my deep breath in, I'm gonna go as hard as I can. Okay, so when you're at a pulmonologist, because you're not gonna get a pulmonary function test at the clinic, okay, that's not something you're gonna have. You have to go to a specialist, a pulmonologist that's going to perform this test. So what they do, if anyone's ever had this done, if you've had asthma, they'll put you in this little like telephone booth looking device. It looks like a clear glass you can see through. And they do that so then that way you're kind of in one little area and not exposed to other things. So then they put on these devices to measure the amount of air you're doing in 1 second. They also do it in 2 and 3 seconds as well. So what's kind of the anticipation here for COPD? Remember they have trapped air. They don't get the air out, right? So their expiratory volume is not going to be as good as someone who does not have COPD. Okay, it's 38%. You also get a couple other diagnoses. So you do have hypertension on there, and GERD, and chronic pain. Now, although I still like to know that, is it pertinent for today? Not really. Okay? Some of your medications are going to go with that, but today, I really don't care about that stuff. I care about the respiratory component. Also, he had appendicitis at 34. He had his appendix taken out. He had a broken nose and broken right arm as a kid. Not really applicable for today. But if I ever have to do surgery on this patient, I might ask how his surgery went for his appendectomy, right? Something like that. But for the most part, those are distractors. We care about the respiratory stuff. Even before the medical history, I saw that he was a 68-year-old man here for phase 2 pulmonary rehabilitation, and this is kind of the intake or the history that we're gathering on this patient. So there are different phases, which I'm not going to ask this on the test, but just to tell you that phase 2 typically happens after hospitalization. So phase 1, you're typically in the hospital. Phase 2, we start to think about how do we get you out of the hospital? How do we make sure that you're educated and know this stuff? Okay?
So for the exam, are we gonna have to know the phases?
No, but I'm just like, phase 2 just means they're not in the hospital. The only reason I'm saying that is because you're like, what's phase 2? And when you're studying, you're gonna say, is Megan gonna ask that? I don't want you to dwell on that. That's not something to study, okay? Okay, so how is COPD diagnosed and what tests has Jim had done? So let's go look at our study here. So he has a lab done, physical assessment. He has has kind of a little history on there, and he obviously had pulmonary function tests done. So in pulmonary function tests, there are more than just the forced expiratory volume. They do a bunch of other tests too. For this test, you just have to know what the forced expiratory volume in 1 second, what that means. So if you were to explain to Jim, maybe he's never had pulmonary function tests done, how would you educate someone that's never had it done on how that's going to happen? So let's say Jim comes into, we're just gonna use Grasslands or the clinic here in town because that's where we're at. Jim comes in, he's got an early diagnosis, potentially has COPD, but we haven't diagnosed it yet. What is the process of him going to a pulmonologist, right, and getting these tests done? What do we educate him on? Because he'll go, Amara, do I have COPD? And you're gonna say, well, you have some symptoms that are consistent with COPD. Your x-ray shows that you have probably a risk factor for it, but what is the gold standard to diagnose? Pulmonary function test. So we would say, pulmonologist does not exist in this town. You have to go to Sioux Falls, see a pulmonologist, and they'll do a series of breathing tests, one of them being this forced expiratory volume, and that will give us more information. That is how you diagnose. We do not diagnose just based on symptoms, right? Because symptoms could mean something else. So this is going to show us more about what's happening inside of that lung. So pulmonary function tests. What other things in your study were you like, oh yeah, that looks like COPD? Or some risk factors, things that go with it, you're like, this has gotta be COPD because I found my little scavenger hunt here of things to support it. Smoking, okay, so he's got an 80 pack per year of smoking. He did quit last year, so we applaud that, but it is still a risk factor. He's got the x-ray that shows the flattened diaphragm. He's had secondhand smoke, and look, his parents owned a family restaurant. There was a lot of cooking fumes. So back there where there was cooking and stuff going on, he might have been exposed to that long term. His dad had it, good one. Family history, family does tell all. So dad had COPD, those are risk factors. He died at 69. How old is he? 68. Does that mean that we should be like, well, your dad died at 69, so you got about 1 year left? No, every person's different. Every situation is different. Yes, there's a risk factor there, but his destiny is determined on what he does now, right? And what he's going to do for his treatments. Okay? Anything else? Let's look at labs. Anything there that you're like, it looks like COPD if I've ever seen it. Okay? Have I ever talked about 50-50ers with you? Okay, so what is the 50-50ers I'm referring to? It's your ABGs, there's just 2 factors in there. No, we're not interpreting ABGs for this next test, but you have to know normal CO2 in the blood, which is 35 to 45. His is 51, so it's higher. He's retaining CO2. What is normal PaO2? Anyone know? It's the direct measurement of oxygen in your blood, so you know how you're oxygenating. 80 to 100 is normal. What is he at? 59, okay? So it's not exactly 50-50, but it's in the 50s, right? So you're kind of the grand scheme. What if on the test I put a PaO2 of 60 and a PCO2 of 49? It's not 50-50, but it's pretty damn close, right? So you know, and it's even abnormal. It's still not in the normal ranges of what those should be, but they're pretty close to that situation. What other labs look kind of odd? They're off. Anything else that is not normal? Say that again. Okay, sodium's, it's normal, and potassium's normal. You say chloride, is that what you said?
No, sodium wasn't it 135, 145, so it's like almost.
But still normal.
No.
I mean, you're right. I mean, if it was 146, yeah, it's normal. But again, are we jumping over seats? Probably not. Okay. How about the red blood cells and the H&H? Those are kind of a family, right? So H&H and red blood cells all tell you the same thing, and they're all going to be high together or all going to be low together. So we've all been taught that low hemoglobin hematocrit means bleeding. Okay, everyone in this room could say a hemoglobin of 7 means probably some bleeding going on. What about a high hemoglobin hematocrit? What the heck does that mean? You might have seen this word before on a test. It's called polycythemia. Okay, so themia are in the blood. The site is referring to the cells, and there's a lot of them. Okay, so polycythemia is when you have increased heart or hematocrit, hemoglobin, red blood cells, But think about what your red blood cells do. It carries what into the blood? The oxygen, okay? So you're like, well, COPD doesn't have good oxygen. Why is it high? It's because it's an overcompensation long term. So typically people that have COPD tend to have higher hematocrits and higher red blood cells because it's an overcompensation. NCLEX loves this because you're like thinking, oh, I got this down, COPD, oxygenation, checks X-ray, I know what COPD is. And then they'll throw some red blood cells and hematocrit at you and you're like, huh? What does that mean? Okay? So polycythemia is typically found in a lot of people that have COPD. It's an overcompensation, or they're trying to compensate for their low O2, so it produces more red blood cells. It's like, hey, if I have low oxygen, I'm just gonna make more red blood cells, maybe that'll help. That's what it typically is trying to do, okay? So polycythemia is something you can see with long-term COPD. Okay, let's go to the physical exam. Picture this person walking into the clinic and having these issues, and think what they look like. Because if I said, Jim's out here in the hallway, he's gonna come in and he's going to show you what he looks like, think about what he looks like, because in a care plans will tell you based on the diagnosis what you can expect for next time, okay? Now not everybody meets the textbook description, however, a lot of them do, okay? So this person comes in and when we listen to his lungs, we hear crackles and we hear wheezes. He has visible accessory muscles. So, there's a perfect picture. I wonder if I can get rid of it here. There's the guy with the neck. Oh, here, this one. Okay? He even looks like he's pretty frail and older, but their neck muscles will be way more pronounced. So if you look at, like, obviously my neck, it's not having like depression, but you will see their accessory muscles, like their scalene muscles, their sternocleidomastoid, and their rib muscles, right? The ones that protect their ribs. You're gonna see more, and it's kind of hard to see, but you can definitely tell when someone's stressing to breathe, they look like, okay? So we can see his accessory muscles. His O2 sat was 93%, and then it looks like they put him on a little oxygen, probably for the sake that he was struggling. So they gave him a little bit, and then he's at 95%. So where do we like to see O2 sats in a COPD patient? It's not 100%. I would say around 90 to 94 in that frame there. So it's not a bad place to be, but he may not need the oxygen after a while. Okay. Respiratory rate was 24 shallow. So shallow breathing means you're not getting oxygen to where? Alveoli, which could cause issues with oxygenation. And then heart rate's 94, not too worried about that. Blood pressure was a little high, and he's got a little edema on his legs, okay? So, I want you to think about this. Cor pulmonale. So I just told you what cor pulmonale was, right-sided heart failure. And this person does not have congestive heart failure. It's not a heart failure issue, okay? Or I should say, it's not a chronic heart failure issue. This person is not having good ventilation, which is causing that right-sided heart to be stressed. The fluid backs up into the spleen or the liver, the JVD, and into the extremities. Okay, so sometimes they have little bits of edema inside of their legs because of cor pulmonale. Okay? Okay, next question. We already covered that one. Medications. So risk factors, we talked about smoking, dad having it, some of those exposures, we already talked about that. What are the meds that Jim is taking? We'll start with the first one, prednisone. What is it? It's corticosteroid. He takes it every single day. Okay, so this is not something you take for 3-4 days when you're sick. This is something he takes every single day. So corticosteroids, absolute must with COPD. Every COPD patient is on steroids, whether it's inhaled or it's oral. Okay, but it's going to be every day. Next one, Duo-Nebs. Did anybody Google this? What's in Duo-Nebs? There's 2 meds, Duo, 2. Albuterol is one, which is a short-acting bronchodilator. There's another one. What? Ipratropium. ISO short, remember? It's all coming back. Ipratropium is a short-acting anticholinergic. Okay? Both of those are bronchodilators, but one works with opening the bronchioles, the other one works with the anticholinergic process. okay? Drying up the secretions and doing it that way. So Duo Nebs is the brand name, but those are the two components in there, okay? Ibuprofen is not related to anything, but he had a history of what? Chronic pain. Maybe some knee pain, hip pain, those kind of pains. And then we got metoprolol. He has a history of what? Hypertension and Tums because he has a history of GERD. Okay? You're kind of tying that all together. Is there anything for medications that he could be on, but he's not? And I'm not talking short term, but just even long term. What other meds could we give for COPD? Anything else you can think of? So we talked about bronchodilators, the short acting ones, but we didn't talk about the long acting ones. Do you remember any long acting bronchodilators? Tiotropium, good job. That's more the anticholinergic one. ISO short, T comes after I in the alphabet, so that's how you knew that one. Formoterol and salmeterol, okay? So they have the O at the end, like albuterol, but those other ones are long acting. So this test, if you had it on your quiz, you have the question where it said, you have a person that has an issue, you give the short acting bronchodilator, then you give the steroid, or then you give the long acting one. So you have to open it up and then give the second medication. So that's where pharmacology comes back into this test, is some of the meds that go with it. Okay? Also inhalers, like sometimes you just give NEBs, it could be NEBs or inhalers depending on the person. Okay? And we just talked about labs. Any education you want to give Jim today? Some things that you're going to tell him that this would be a good thing to help prevent this to get worse again, or things that would be helpful for him. Elevate the head of the bed, so just kind of helping with more of the supplemental things. So maybe a lot of times these patients will say, I sleep in the recliner. That's very possible. But maybe having the head of bed elevated so that helps with breathing. Would you say, Max? Okay, so triggers. What are maybe triggers? Smoking, he said he quit, so that's great. But what if he didn't? They say that any amount of smoke. So if people are saying, I'm still having 1 to 2 cigs a day, they'll literally say that. I'm doing good, right, Megan? I used to do a pack. Yes, you are doing good, but what is the ultimate best thing to do? So smoking cessation, because that irritant is still there, okay? No matter if you have 1 or 2 or 20, you're still having it inside your body irritating it. So we applaud him getting down to 2 cigarettes. Our ultimate goal is cessation, getting rid of it. Triggers, so let's say potentially his trigger now is maybe he has a pneumonia on top of this. Maybe he's sick, okay? So sometimes COPD patients, if they're very high risk, we tell them to avoid areas that have infection. So large gatherings are typically avoided for people. What about immunization, vaccines? Flu vaccine, even like the pneumonia vaccine, if they have a high risk for pneumonia, so they can get that. So flu you get how often? Not flu itself, but flu vaccine, yearly. Pneumonia vaccine is typically every 10 years, okay? Now, the reason why I say every 10 years is because some people that are high risk, for example, COPD, if you got diagnosed at 48, we tend to not give the pneumonia vaccine until you're 65, unless you have high risk. So, theoretically, if you got it at 68, you probably only need it once because you might be potentially not here in 10 years. Now, not always, but they usually say 10 years is enough in order to be protected against pneumonia. Okay? Other education, and think about infection. Washing our hands, avoiding large crowds, taking your vaccinations, okay? Wearing a mask if you're in a high-risk area. So those are things to prevent infection. What other things? Erica, what do you want to tell this patient for education?
Try and do like small amounts of exercise.
Okay, so trying to build up stamina. So that's a good thing too to help with endurance. And when would we tell him would be the best time to do this? Maybe multiple times a day, or if you can only do it once in the late morning. That's a great option for him, okay? Consider the goal of this person's not gonna be doing 30 minutes a day, 5 days a week. I'm not saying always, but in most cases, they're gonna need short bouts of exercise, okay? Taking your medications. What if he shared today in his visit that he hasn't been taking his steroid every day? I forgot, or can't afford it, or I don't have a card to go get my medications, okay? So let's think outside the box here. What's the first thing we can do for lack of travel? Delivery. They have delivery services now for medications. So now with technology, we've gotten better about giving medications because they can be delivered. So maybe that's something that is an option for him. Okay? What about financial? Can't afford it. Okay, so insurance is great, but not everyone has insurance. So what can we do? can look for potentially, sometimes we have samples in the clinic, but also like there are apps that have like discounts, kind of like coupons for meds. And then also think about generic. Okay, generic might be a better option. We don't need the brand names. We can do generic and get away with a lot cheaper. And then if that isn't the case, social services. We might have to refer to social services. They might be able to, essentially get grants and things to help the person pay for their meds. Okay. All right. Any other education? Let's look on our slides here. This is where your education is going to fall. Okay. So if one of your nursing diagnoses was, I want this person to make sure they have good airway, make sure they have good oxygenation flow, here are things that we might be able to do with education, okay, or things that we can do for the nurse. So why do we encourage fluid? Now I'm not talking someone that has heart failure that has restrictions, but what is fluid going to do for this person that has a lot of sputum? It's going to thin their secretions, right? So sometimes we say drink lots of water, like within realm, maybe 8 glasses of water a day, to help keep your secretions nice and thin. Because one of the most common things these patients are on are anticholinergics. Okay, so what does anticholinergics make you do? Dry. It dries you out, which great, that does help with some of the secretions, but now the secretion is dried out to the point where I can't get rid of it. Okay? So one of the medications they might be able to be on is expectorants. Think back to the commercial I talked about with expectorants. Mucinex or guafenicin, the little booger that can't get out, and then all of a sudden you take the expectorant and it coughs out. But there's one key thing you have to do with guafenicin. You have to drink water, okay? Because if you don't drink water, it's going to get stuck. It's going to try and try. Water will help it, okay? Some kind of just little bouts in the hospital. We always, with people with respiratory issues, will not check them once a shift. You guys probably know by now that if you see something on the test about time frame, once a shift typically is not how often we assess problems that are higher up in severity, okay? Every 4 hours minimum, if not more often if they're unstable. Coughing and deep breathing, incentive spirometer. At clinical, how often does it prompt you to chart on incentive spirometer? Every hour, and you're like, oh my God, like it's excessive, right? However, if it didn't have that reminder, would you do it? No, it's doing it for a reason, right? So it's trying to prevent the person from getting worsening things with them, okay? You probably have never seen this before, but orthoptic. It's a type of ways that we can position people, but this is kind of the tripod positioning, but they kind of have their side table in their hospital room, and they have the hands on the table. But they're leaning forward with their hands resting so they don't have to hold their body up. If you see this positioning on a patient, they're typically shortness of breath and dyspnea. They're not having good adequate flow. So that might be kind of your sign to, I should probably do something. Give a neb, give a medication. Okay. Suctioning, we will talk about further as we talk about skills, but I'm going to teach you about when to suction and why to suction here in the next couple weeks. Okay? But suctioning could be an option for them too. Okay? Here come your medications. So if I had a patient that had multiple meds on their list, always look for the bronchodilator first, no matter what the med is. Because if I give an expectorant, if the bronchial tubes are not open, nothing's coming outside of that lung. So open the lungs first and then give your other meds. Okay, pursed-lip breathing. Have you heard that before? Okay. What is a good way we explain this to patients? Because if you said, hey Ryan, why don't you do some pursed-lip breathing for me? The patient's going to look at you and be like, what? Okay, we always say, smell the roses and blow out the candles. And people tend to be able to focus on that. So if you focus on something else besides their shortness of breath, it slows their breathing down. So we say, smell the roses, breathe through your nose, and out through your mouth. Okay? And the whole part of pursed lip is so when they breathe out, we want to breathe longer than when we inspire. Okay? Because they retain CO2. They tend to breathe shallow and they don't exhale very long, so they trap it. So we want to exhale longer than we're inspiring. Okay? What is the ultimate goal of pursed lip? It's not to, it's not to get rid of COPD, it's not even to really help the chronic issue, it's to get their CO2 levels better, or like to get rid of CO2. That is the goal. Get rid of carbon dioxide so they can breathe more efficiently. Okay? Abdominal breathing is the same thing. Do not confuse those on the test, they're the same. So if you ask someone, the whole point of the abdominal part is they hold onto their stomach and they're trying to focus on breathing in and breathing out, and when they exhale, So when they're breathing out, they can kind of push their stomach to push the alveoli, so then therefore they're getting rid of that CO2. So they really kind of push their belly in when they're trying to exhale. Okay, it's kind of a weird thing, but it works. Okay, paper bag. Okay, why do we use paper when it comes to a lot of sputum? Okay, we're trying to look at it for one, because a lot of people will flush it down the toilet. And a lot of times in your rooms, have you noticed on your tables, there's that little paper bag, okay? They want them to put them in there and not swallow your sputum. You get the people, they go, and they hawk it up and they swallow it, okay? I'm not saying that they can do what they want, but we want to get rid of whatever's in there and see it, and actually be able to notice what it is. Can you get a sputum culture from a tissue that has like a loogie in it? I don't only call it a loogie because it's like the sputum, the yuckiness, right? Big, thick, tenacious stuff.
No.
No, you have to get it fresh from the source. So the best way you can do it is if they hawk up something, they should spit it right into the container. Once it goes into a tissue, it's considered not acceptable anymore. Okay, so you have to make sure it goes right to the source. What if they can't get their sputum out of their lungs? What might you have to do? Go get it, get a sample. So suctioning, we have little devices that connect to the wall. You can actually put a suctioning device down someone's lung and suck it out. And inside of that tube is where we'll get our sample. So yeah, we might have to go get it. It does happen. Okay, we're gonna talk about a little bit more on this on Friday. We're gonna start, I'm not quite done with COPD. I wanna talk about some more needs to knows. And then, there's one little activity I want you to do with this. So we'll probably spend about 20 minutes on COPD on Friday, and then we'll go to asthma. Okay, so asthma, once we learn this with COPD, asthma is very easy to understand. They're very similar in